This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Robbie Thornsberry, who is Chief of Staff at the Medical Center of Central Georgia, and many other things besides. Is that correct, Robbie?
I think so, yes.
And so you've had an interesting journey through life. I believe you're an orthopedic surgeon. Is that correct?
That's correct. I'm with Ortho Georgia, with offices in Macon and Warner Robins.
Yes. So you've sort of been exposed to the American healthcare system in a vigorous way, and your position is an important one now at the medical center. Is that correct?
Yeah, I'm the chief of staff at the medical center. So, and in addition to that, I'm in private practice with a group, a medium-sized group by today's standards, and so I see it from both ends. I see the hospital problems and the problems with private healthcare.
Yes. Now, one opportunity you have tonight is, in general, many people don't get a viewpoint, I'd say the physician's viewpoint, about the way that the American healthcare system is being restructured. So both, I think, you and I encounter some of the disjunctions that sometimes takes place, some of the problems that we face, and there are lots of them out there. What do you think is going to happen next year when the full impact of the Affordable Care Act occurs? Do you have any thoughts about that? Or
to put that in 100 words or less is impossible. I think that you can see that the Affordable Health Care Act, their goals are far-reaching. Their goals may be unobtainable, and from a physician's point of view, it becomes a huge burden from the paperwork point of view and from just not knowing what's going to happen. I think the public doesn't know what's going on with the Affordable Health Care Act for the most part. Neither do we. Neither does Congress. I don't think anybody knows.
Yes. So a lot of this is, the problem, some of the problems we have is so much of this is taking place in the dark. The regulations that are being propagated, the arrangements that are being put together, and it's a little bit disjointed. Is that a thought on that?
Well, you know that change is coming.
Yes.
But you know about when.
Yes.
January 2014.
Yes.
But you don't know exactly what it's going to be.
Yes.
And you don't know how it's going to. You don't know 100% how it's going to affect you. You can't make a plan. You can't, from a patient's point of view.
Yes.
My patients come in the office, they're scared to death.
Yes.
I treat a lot of elderly patients, Medicare age, and when you talk to them, they're scared to death, and they're probably the least affected possibly by the Affordable Health Care Act. It's people who are in their 40s that need to be thinking, how does this affect me?
Yes.
And it's going to affect them greatly, and I think that this Health Care Act being a moving target is going to make it difficult for anybody, patient, doctor, hospital, anybody. Nobody's going to catch up with it, and that's one of the problems.
Well, one of the things that goes on is the power of the government is going to be substantially increased under these new arrangements. One thing that happens, in my experience, is that there's something called down coding. And maybe you can talk about that. But so the government may say there are codes for different kinds of procedures, different things that are done to patients. And the government can often, with their apparatus, change the coding arrangements. So, I mean, hasn't that had an impact, at least on older patients that undergo orthopedic surgery? Is that something that's happened?
Well, as a general rule, anything that you do a lot, any common procedure, in the government systems, they, as you called it, down coding, they basically, the more you do of it, the less you get paid to do. So anything very common in the government health care system, you get paid less. And that, of course, is a problem for physicians, but to date, for the most part, physicians can keep up with it. You know what to expect, and you know what's going on with the New Deal. As government gets more power, in other words, as they become more and more of a monopoly in healthcare. I think right now most people would consider healthcare insurance companies an oligopoly.
Yes.
But you're moving towards a government-run monopoly where I would say 3 to 4 years down the line, there is going to be a definite two-tiered healthcare system, and those who can afford it may have private insurance. Others will probably be in a single health care payer system, and they'll control they've got all the marbles. They can tell you what they'll pay you and how you will get treated. And I'm not going to sit here and say that it's all bad, because there's some good things about it, but when one person has all the marbles, it's a problem.
Well, let's talk about that a little bit, the government control, and I'm sort of going to bounce the basket a little bit about on the government's ability to downcode things or pay not only physicians but hospitals or any kind of providers whatever they want, pretty much. And that has a pretty substantial impact on the healthcare delivery system. For instance, at the medical center, they've got which is a huge hospital. It has lots and lots of people that come there. It looks after a lot of people. They're pretty vulnerable as are all hospitals and all healthcare systems to what the government says is the appropriate amount of money to make their system work. So, I mean, one of the things that concerns me a little bit is the purpose of allegedly the Affordable Care Act is to make sure that lots of people that don't have access to health care obtain it at a small price. And it appears to me, the way the system is going, that the result may be the opposite. And maybe just talking about downcoding, if the system that's in place now may mean that a lot of the more marginal hospitals and practice arrangements could be tremendously impacted by the government's changing the arrangements of how they compensate different parts of that program. And if that were the case, many of the rural hospitals that are out there in this part of the country might not make it. The providers in rural areas might not make it. And the burden, those patients that are vulnerable, those patients are going to find their care in a hospital like the medical center that's going to have a lot of financial issues. Any comments about that?
Well, when you look, right now, the smaller hospitals are struggling mightily as it is now. They have been struggling. The state government largely has been able to support them throughout a lot of the recent times. With the Affordable Care Act, some of those hospitals there's no way they're going to be able to make ends meet. And so there's going to be, those hospitals are going to turn into, instead of acute care facilities, they're going to turn into more urgent care facilities, with the influx of patients moving towards the larger regional hospitals such as the medical center. And the medical center, being a kind of a super regional hospital, will be getting a tremendous amount of patients. Hospitals the medical center is the largest employer in Bibb County, and it's a huge business, and even on the surface it looks like they would do very well. There's not a huge margin, and when the margins start shrinking, they are dependent on a lot of different factors with the bond ratings and things, and when those things start getting affected, it affects the patient care. There's things that come down to the patient. You can't get new technologies. You can't do this, you can't do that. If you get downcoded,
yes,
and if they're getting paid less and less and less,
yes,
they have to make changes, and those changes affect patient care. There's fewer nurses. There's less trained nurses. There's less specialty physicians, if you will. The physicians have to make decisions. What am I going to treat? Am I going to stop doing this? Am I going to stop doing that? And those things ultimately affect the patient. And the patients, with the Affordable Health Care Act, what does it mean? Or are they trying to give coverage to everybody? Well, if you give coverage to everybody, which is a great thing, and no, I don't think very few Americans are against that, and certainly very few physicians. But if you do that, it is at a cost. And the public needs to realize that is going to be at a cost. And if you're trying to curtail healthcare cost at the same time you're trying to expand coverage, those two things don't work together. And if they do, it is highly inflationary. And the state government, Georgia, is one of the states that has a balanced budget in their constitution.
Yes.
So they cannot just say we're going to spend $20 billion more on health care, because that $20 billion has to come out of the state budget, which either you increase the state budget, which means more
Yes.
taxes to you and
Yes,
I,
right.
or you go the opposite way and say we're not going to do it. And right now, the governor has decided we're going to watch
Yes.
and see
Yes.
what happens. So all these things are there's and they don't have to be totally independent of each other, but you can't have a great expansion of the number of patients that come into the system at the same time cutting costs tremendously, which is what it looks like a lot of things going.
You know, maybe I can take you back. I know that you were besides being a football player in college, but you were a scholar, and maybe you tangle with economics 1 in your travels. We have these supply and demand curves. And so the American people need to understand a little bit about what's happening here. So allegedly, the demand is going to increase, allegedly, for healthcare services. Allegedly, maybe, probably. Yes, the answer is yes. At the same time, the supply of physicians and hospitals and services that look after physicians look after patients rather, is at least flat. And we can talk about the supply issues that it's very difficult to train physicians, to get them in the hopper. So there are lots of reasons to suppose the supply curve is being flat. And at the same time over here, the price is being reduced by government fiat. So you have a system where, if just going back to a little chart, when these circumstances exist, what that does is it causes shortages. So you have shortages that happen. And one of the things that concerns me is the shortage of healthcare services is effectuated. The people that won't get access are going to be those people that have the worst insurance policies, that are Medicaid patients, and those patients. There's still a substantial number of patients that sort of fall between two stools here, as I understand it. Is at getting appropriate health care coverage. And in Georgia, the idea is that they're not going to expand the Medicaid rolls. So I'm quite concerned. There are going to be patients that are going to have worse access than they've had in the past. Any comments about that?
There's going to be a lot of people who, even though the goal is to have every person in the United States have health care, that's at least in Georgia, that's not going to happen. There's still going to be a lot of uninsured. The Medicaid rolls, they're not putting more money into Medicaid, so that's going to be a shortfall there. And there's also going to be some employers that will pay the fine instead of providing insurance. Now, employers have a year's break, but at some point this is coming, and they're going to say, hey, it costs me X number of dollars a year to keep you insured. My penalty that I'm going to have to pay is less than that number, so I'm just going to put you out there and pay the penalty, and you go find your own insurance. Well, there's not a lot of exchanges in Georgia right now, which is what there's going to be health exchanges where you will go and you'll go online and you'll find the insurance policy that fits your bill better. Well, those may not be as good of insurance as what you had before. There's going to be shortfalls there. So people you may still have uninsured patients, and then you're going to have a big vat there that are underinsured. And a lot of those people are going to have difficulty finding health care due to supply and due to different things. And then you're going to have people who are insured, and then of course the Medicare and Medicaid who won't be largely affected.
So just to ask the question, I mean, who knows what's going to happen, but is this going to propagate a two-tiered healthcare system? In other words, are people going to find a way around just the difficulties that we see coming? And they're going to say, well, look, I've got a lot of money, or I'm going to have some kind of premium arrangement, and I'll do whatever it takes to get first-rate health care for myself and my family. And then everyone else is going to be locked into this sort of, I guess, general population that the government is going to have inadequate funds to look after. And they're going to be the major providers of the funds that look after the healthcare system. There won't be enough to go around. And so the quality of healthcare might substantially decrease. Is that a fair?
There's a big circle. And if you look at a young guy or gal coming out of training right now, and if they are looking, where am I going to practice medicine? If there's a two-tiered system, which is, there will be some semblance of a two-tiered system. You'll have a government-supported and government-subsidized system if things work the way that I think the Affordable Care Act says. And then you'll have those that will have insurance. And so those people who have insurance, or a supplement, so to speak, they're not going to be in the northern suburbs of Atlanta, if you will. And there will be a shortage of physicians and general healthcare workers, and not just physicians, nurses, and everything else, all types of therapists, because they'll go more there because they will have more access to insurance, and I predict a shortage eventually of all healthcare workers.
Yes, and just to look at the situation. So, I mean, I think that it's sort of like being the canary in the coal mine. I mean, the physicians are the last people anybody's talked to, in my opinion, about this extraordinary change in our American culture. They just didn't have a place at the table. Is that a fair statement when the reforms were going through?
Well, we don't know. That's part of the problem. We don't know who had a seat at the table. I don't think anybody knows. And the physicians who were there tended to be, they're not physicians on the front line. They're not people who see patients day in and day out. They tend more to be academic physicians or physicians who were in different types of healthcare plans or healthcare positions where I think that they had are more theorists than realists.
Yes. And in your position at the medical center, I mean, you see there are 500 or 600 doctors that are on the staff there. Is that the right number? Lots of.
There's 640 or so.
640 doctors. So you're right in the belly of the beast, so to speak, about all the things transpiring, and you see a lot of the disjunctions that are out there. One of the things that concerns me, just going back to the idea of this two-tiered healthcare system, is that if there's let's say some kind of healthcare system that has a higher proportion of insurance-paid patients in that system, then they're going to be able to get cutting-edge technology, and they're also going to be able to have better, in many ways, better results because of the number and quality of physicians they'll have in that institution. I mean, that's a debatable point, but I think it's a fair assertion. So and when that happens, the government system rewards that institution. So a system, a hospital or healthcare apparatus that has a lot of indigent patients or underinsured patients that go into that hospital or that apparatus, the amount of money that's present to get cutting edge technology and to really get great results is diminished, and it makes it a lot harder to do that. And the government system punishes that hospital. And so it just compounds the difficulties that seem to be coming at us very acutely. Any thoughts on that?
Well, there's kind of two different things, and a lot of this, what the government and other insurance companies as well are calling value-based health care. They want better value out of your health care. They want high quality at less cost. So, and that's reasonable. Anybody wants that.
Sure.
I mean, that's a great goal, and that's a goal that, frankly, we strive for
yes.
as best we can. But what happens is that if you've got a patient who has had better health care their entire life, they're overall in better shape, their weight's controlled, their high blood pressure's controlled, all of these things are controlled. If you operate on them or they're coming to an acute care hospital setting,
yes,
they will have better results. But one of the things I like to say frequently is no care is not
yes.
good care. So if somebody comes in with a problem, you don't always get dealt the best hand. You have to do what you can with it.
Yes.
And the hospitals are in a position, more so than physicians, where they are not going to get compensated for complications. They're not going to get compensated for infections. They're not going to get compensated for a patient that gets readmitted. They are basically telling the hospitals, you have to be the keeper of these people, and you have to, if somebody goes home with diabetes, you have to take care of them, which is a tremendous burden. That's obviously higher cost, and it's higher cost, and it's higher more people. You have to have a tremendous outpatient function on these things, and it's the pie in the sky, which would be wonderful if you can do that, but they are penalized in the short run and in the long run. So it's going to be very difficult for hospitals. Hospitals may eventually come to a doctor and say, I know that you're cutting edge, you're doing a great job, but your clientele's not good. We don't want you here.
Well, let's talk about that. So is the way, if we discuss the sort of financial nexus of what's about to occur here, obviously the system is going to have a lot of problems with this, with increased demand, diminished prices, and a supply that's either diminished or flat, so that it's not going to work. There's going to be a shortage. Normally, let's say in a socialist country, the way these shortages are dealt with is by a word you call rationing. So what is the de facto rationing policy that maybe exists to some degree right now, but is really going to be a big deal in the future? And we can discuss that a little bit. The idea of rationing might be that if you have a lot of comorbidities or a lot of things wrong with you and you need elective surgery, the government might hatch out regulations that make it impossible for you to get in and get the procedure. I mean, maybe that's one factor. Or maybe whole parts of the country might not have, let's say, I know you do a lot of joints, you do joint procedures, but there might be a particular part of the country where you just wouldn't be able to get that accomplished because there wouldn't be any physicians practicing in that area because of the financial arrangements that existed. I mean, is that sort of a de facto rationing that might be hatched out here?
Well, it's like if you go back to your Economics 101, and when you got a classic supply-demand curve, and if you have less supply and high demand, the price goes up. Well, the evening out factor there is the government.
Yes.
And the government can get to a position where they can tell you, we're going to do this, we're going to do that, we're going to change this price, we're going to do this, and the regulations come on you, and as the regulations come on you, it makes it difficult to do things when you're told what to do, right? And there's a flux there, though. There's a build up to that, and January 1st, 2014, you're not going to see it. Not a lot will change, but as gradually things happen gradually, where all of a sudden you can be in a huge problem. I mean, your specialty in neurosurgery, it will be neurosurgeons. You need them more than you would think, and so
they're a rather charming group.
That's right.
Say.
That's right. Yeah. But if you get to that point, we need neurosurgeons are needed everywhere, and there's just not that many of them, and as you're regulated and things, and told what to do, people will find a place where, and it may not be in this area of the country.
Just one of the things that's out there that I think the American people should keep an eye on, and it's this, is that I think in the past, at least, the idea was if you're an American citizen, one of the rights and privileges you have as an American citizen is to get first-rate health care. You're going to find a way to get good health care, and the physician is going to be your advocate. He's going to be in there treating you, not worrying about the government, not worrying about anything else, just your problem. And he's going to do everything possible to get that taken care of. And in general, the system has worked where that's not a false hope. But I'm concerned that as the system changes, there'll be that the physician can no longer be the patient's advocate, because the mountain of regulations and shortages the system is imposing is going to make it difficult to really get the kind of care we'd like to give our patients. And for instance, it might be, one thing is, maybe the hospital could not afford to have the ORs open enough. So you couldn't, if a patient needed an elective procedure, it couldn't be possible to get in there and get the case done. Or it might be that the arrangements that exist for paperwork make it so daunting to get anything done that it's almost impossible to get things accomplished. The government might require things in triplicate, or if you take my point. And I think already the regulations and oversight is often extremely clumsy and unthinking. Any thoughts about that?
Let me state that I think as a general rule, physicians fight hard to try to be the patient's advocate, and we try to be efficient. And sometimes patients can misinterpret that as being uncaring and this, that, and other. But I think generally try to have the efficient system and try to provide this value that we've talked about, which I think, that's a good thing. But the problem with it is when you're riding on bald tires, and you're at risk.
Yes.
And as the tires get more and more bald, if you hit a wet spot in the road,
yes,
you start slipping and sliding. You get flat tires and things. Well, we're getting closer and closer to that point where your tires are getting more and more bald, and you're going to be, at some point, there's problems. And that's the whole thing that we keep talking about and coming back to is you're asking for everybody to get covered, but you're asking them to do it at less cost. And right now there's not less cost, but that is, at some point, that's coming, because this whole thing started where it's the healthcare is escalating, the cost is escalating out of control, and so.
Which it is.
Yeah.
Which it is.
So you get two different sides to the thing, but when you bring on more and more people, your costs are going to go up, and I think people need to realize that somehow that's got to get paid for.
Well, I mean, there are a lot of things that need to happen. Let me ask this question as we get near the end of our interchange. Is one of the problems that we see just locally with trauma? I mean, are we getting problems with trauma in this area, just trying to make the system work? You have any thoughts about that? Is that one of the issues that's on the table these days?
Yeah, I mean, trauma is if you're in an area of the state like we are, where you've got two major interstates coming together, you've got a lot of, we're in the middle of a kind of a rural area if you look at Georgia, and so like the medical center takes a huge amount of trauma from basically all over South Georgia, which is a large area, and it is difficult to recruit and treat these patients, not the patients, but the doctors to treat them, because it's highly specialized, and they have thrown that burden largely on the hospitals to take care of it. The state and somewhat the federal government gives some funds which are going away with the Affordable Care Act starting next year, 2015. Those funds are going away, and as they go away, there's going to be less money there to support that. And if somebody has a terrible injury, a lot of them are uninsured, a lot of them are underinsured, and that when the hospital takes those people in, they bear that cost. And so the hospital has to fight hard. They have to have specialized physicians to treat this. They have to have 24-hour, 7-day-a-week coverage, and that means you have to have nurses, therapists, respiratory therapists, the ventilators, the intensive care units. It's a very, very intense, highly technical specialty to treat trauma patients, and when that falls on a hospital, those things are becoming where they can't do it, and so the government's at the same time saying we're not going to keep giving you money to do it. So there again, that's a hard thing for a hospital such as a medical center to deal with, and there are problems. Those are not they don't all of a sudden come to a head all at once. It's kind of a gradual process, and something that you've got to be wary of and think about all the time, and they're always trying to stay 2 steps ahead. Luckily, you have a person in charge of the trauma Level 1 Trauma Center at Medical Center, Dennis Ashley, who puts his heart and soul into it. So he works hard with it. but it gets harder and harder.
So just as we sort of conclude our interchange, one of the things that goes on is how does the pricing system work in healthcare? So there's something that's really a good thing to have. It's extremely expensive. It's a good trauma apparatus. And if the system doesn't fund that trauma apparatus, it won't work. And the interchange that takes place in the marketplace, that's pretty efficient. But when you have tremendous government regulation deciding where money does and doesn't go, often it's a very imprecise arrangement. And so we have these shortages or disjunctions or problems. And I think it's going to be extremely important for physicians such as yourself, Dr. Thornsberry, to have a public, access to the public, just to point these issues out.
Well, if you look at Canada, if you have a car wreck in Canada, you are going to get great health care. They have great trauma system. Everything's wonderful. If you want a knee replacement in Canada, get in line. You can't pay for everything when you want to. So that's an example of their government has said, this is where we're going to pour our finances and energy into it. And so those are decisions that they have made, and those are, if you need a knee replacement or a hip replacement, that's not a good decision. It doesn't benefit you. So I mean, I think all these things will happen. They'll happen gradually. The world's not coming to an end because of this, but if you don't think about it and you don't consider all of the things that, if you do this, what happens next? If you do this, what happens after that? It's those sequential steps that gets a lot of legislation, not just healthcare legislation, but a lot of legislation in trouble. And that, with this Affordable Care Act, there's going to be a chain reaction of things that if we're not very, very cognizant of it and work hard to stay one step ahead, it could be very big problems.
Well, thank you a lot, Robbie. It's been great having you with us tonight. This is a good
Enjoyed
interchange.
it.
Thank you. Thanks.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.